All right. Good morning, P10I's Daily Show. Happy Friday morning. Hope your day is off to a great start. We're live here on Instagram, on YouTube, wherever you get your podcasts as well. My name is Alan. I'm happy to be your host today. Currently have the pleasure of serving as the Chief Operating Officer here at ICE and a faculty member in our Fitness Athlete Division. We're here on Fitness Athlete Friday, the best darn day of the week. We talk all things CrossFit, Olympic weightlifting, powerlifting, bodybuilding, and all things to help the individual that's already recreationally or maybe even competitively active. Courses coming your way from the Fitness Athlete Division. Some chances to catch our live seminar out on the road this summer. Next weekend, April 15th and 16th, out in Kent, Washington, in the Seattle area. The Barbell Physio, aka Zach Long, will be at CrossFit Devotion. That's going to be a banger of a course. That's going to be a huge course, about 40 folks total signed up. If you can't catch that weekend, we have some weekends in May coming up, the weekend of May 20th and 21st. We have a doubleheader. We have Zach Long on the road again in Boston, and then we have Joe Hanesco down in Rockville, Maryland for Fitness Athlete Live. And then Zach continues his summer tour the weekend of June 10th and 11th. He'll be in Brooklyn, New York, and then Loveland, Ohio, the last weekend of June 24th and 25th. Learning from us online, our entry-level course, Clinical Management of Fitness Athlete Essential Foundations, taught by myself, Mitch Babcock, Kelly Benfee, and Guillermo Contreras, starts June 5th again. And then Advanced Concepts with Zach, Mitch, and Joe will start September 17th. So that's courses coming your way from the Fitness Athlete Division. Let's get into today's topic. Stop getting surgery. Stop getting surgery. We are an interesting profession in that we advocate that patients for non-traumatic insidious onset injuries try physical therapy first, right? Hashtag get PT first. Whatever derivation you've heard of that, we try to preach it of, hey, come try to get physical therapy first. Try us out first. We're definitely going to match, if not beat, surgery in outcomes and costs. We have really high quality research showing that if you do try physical therapy first, you're probably going to get better faster, and you're definitely going to save a lot of money versus getting an image and getting surgery. So we advocate this to our patients over and over and over again, and we're always disappointed when they choose surgery first or otherwise don't come see us first. And yet, as a whole, as a profession, we also choose surgery first for our own injuries. Very rarely do I meet somebody who doesn't have an excuse of why they can't participate in a certain thing, in a course, or they need some sort of modification because they are currently recovering from a surgery. And I've yet to meet somebody who is recovering from a surgery of getting hit by a bus or fixing some sort of terrible congenital condition. Almost always I hear, I'm going to need to modify. I just had my knee scoped. I just had my rotator cuff repaired. I had some sort of surgical intervention, largely elective, didn't really seem to help me for a condition that I didn't try physical therapy first in regarding. And then we wonder why patients don't come trust us. We wonder why our more athletic populations are always seeking the quick fix, the toe spacer, the new kinesio knee thing I saw that's lasers that goes around your knees for patellofemoral pain. Why they're always chasing the quick fix? Well, because they see us chasing the quick fix. So I want to spend today talking about some of the data supporting why we shouldn't be doing that, and then also the practical applications of what happens when we choose PT first, what tends to happen in that regard. I think we need to start with the data and recognize that, especially in the United States, we really get a ton of surgeries. We love surgery in the States. We love elective surgery in the States. If we look at across the planet, 300 million surgeries are performed every year. Much like everything else in the world, the United States overconsumes its fair share of that. About a fifth of all surgeries happen in the United States. In Western countries, particularly the United States, almost every surgery that happens far and away is elective. There's a ratio called the EE ratio, big E, little e, emergency to elective. How many emergency surgeries are performed for every elective surgery? Which tells us a couple things. The state of kind of the medical system in the country, how developed it is, if more preventative medicine is available, or if everything is emergency. But also when we see a lot of electives compared to emergency, we know that we're getting a lot of cosmetic surgery, a lot of non-traumatic, non-life-saving surgery. So when we look at the EE ratio across sub-Saharan Africa, other under-resourced parts of the world, that ratio is over 60 to 1 of 60 emergency surgeries per every elective. So almost overwhelmingly, every surgery is for an emergent life-saving condition. It's almost the opposite in the United States and the Western world at 5.5 emergency surgeries to electives, that there are a lot more elective surgeries and there are very few emergency surgeries performed by comparison. Overwhelmingly, we overconsume surgery hours in elective surgery hours, that about 90% of the surgeries here are elective. They are recommended, yes, but will they change the outcome of you living or dying? No, they won't. They are for cosmetic purposes. They are to maybe try to reduce pain or some sort of symptom, but they are not a life-saving emergent surgery. They're also very, 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 very expensive. We spend a ton of money on our healthcare, both from a government perspective, but also on a personal perspective. We spend about 25% of our total GDP on healthcare. What that means is all of the collective buying power of our country, we spend about a quarter of it just on healthcare. The average American will spend about $10,000 a year on healthcare. That's outside of whatever insurance costs they may also have if they happen to carry medical insurance. And then of all that, we spend about 10% of our total money on surgery this year and every year after that. So when we look at those numbers, we see that our spending on healthcare and on surgery, which again are largely elective, are currently outpacing the growth of our economy by about 250%, that we're spending more on healthcare than we are creating in wealth in our country. So it's creating this unsustainable curve. If you heard the pilot say, hey, I'm going to reduce the pitch of the plane by about 250%, you would panic, right? That means he's going to do 2 loop-de-loops and go into a nosedive. That's essentially what it looks like if we plot our economy versus our healthcare spending on a graph. It looks like 2 squiggles into a complete nosedive towards zero. So we're part of this problem as well every time we choose to go down and help ourselves to a knee scope or an exploratory shoulder debridement or something like that. I want to share a story of a man who developed a case of radiculopathy last summer. Very severe pain. Could not walk for a couple days, had a lot of foot drop, had a lot of radiating pain, numbness, tingling in the lower leg and foot, had trouble putting his clothes on, putting his shoes on, was in a very rough spot, started to get a little bit better, but still had a lot of trouble, even with sitting, with driving, with day-to-day tasks. Went to his primary care doctor after about 6 weeks, was still going to the gym, was trying to modify some things, but was really just not seeing any sort of shift in the right direction. And went to his primary care doctor, told him the symptoms, and said, what do you think? Do you think an MRI is warranted, or do you think this is enough of a progression in the right direction to continue doing what I'm already doing, which is modifying exercise and just looking to see any sort of progression in the right direction? And that primary care provider said, radiculopathy, tendinopathies tend to be really longer duration injuries, and that we really shouldn't consider surgery until we've been judicious about trying at least 6 to 12 months of more conservative management. And that person was me, and that primary care doctor was my primary care doctor. He told me, continue to take your own medicine for a couple more months, come back and see me in the fall if you really believe that you've made no more forward progress. And so recognizing on our path to, should I get surgery, should my patient get surgery, recognizing that some injuries do take a long time. So better understanding the importance of staying moving and trusting the process and knowing the timelines for common injuries can really be helpful on our own journey with injuries, but also with our patients. Of knowing, hey, like a muscular tweak, we expect to see that start to get better in a couple of days. Like over the weekend, it should really start to be feeling better if it's nothing serious, versus when we're more convinced something is a radiculopathy, a tendinopathy, a longer term injury. We know the changes can be more gradual. The timeline there is longer. But we should also know the same healing timelines for what that surgical process looks for something like that. Of what is the surgical treatment for a lumbar radiculopathy? Well, it's probably going to start with something like a lumbar discectomy. What does that look like recovery? What does that look like surgery-wise? What does that look like cost-wise? We should have that same information available for ourselves and for our patients. Yes, it might take 6 months to really see more forward progress with a longer-term radiculopathy injury, but we also know we look at 2-year outcomes with things like surgical discectomy. We are really not expecting to see a turnaround in symptoms until we've passed the 2-year mark. What do successful outcome percentages look like in those surgical candidates? We should have the research and the stats on those as well available for our patients. It seems high, lumbar discectomy, 75% successful outcomes at the 2-year mark, but 75% is a C, right? Like imagine if a plumber came to your house and your basement was flooding and you said, hey, can you fix this? He said, I'm pretty sure, I'm like 75% sure I can fix this. You would not feel very confident. And also, if he said there's a 25% chance I could make it worse, like you could be worse later on after I fix your basement, you'd be like, wait a second, maybe don't touch it, right? Maybe I call somebody else. 75% success rate, 25% chance to actually make it worse. That's not great. And that's a quote unquote more successful surgery. We know lumbar fusions have a 52% success rate. That's the same as flipping a coin of 52%. Same scenario. Hey, there's a 52% chance I could fix your flooding basement. There's a 48% chance I could make it worse. You'd be like, hey, man, sorry, I'm going to call somebody else, right? I want to hear 95% maybe I'm comfortable with, 52%, no way. And we have to relate the costs as well here of so many patients look at, well, PT once or twice a week, especially if you're cash-based, that's like 200 or $300 a week. That could be several $100s to get this better, or maybe in the thousands. And then show them the costs of something like a lumbar fusion and its aftercare at $20, $30, $40, $50,000. Your insurance doesn't care what they bill towards your deductible, especially if you don't have insurance. You're going to pay that cash all the same. So we need to be familiar with these surgical outcomes, these timelines, these costs. When patients think, I'm just going to try surgery, it seems faster and cheaper. No, it's not. It's often slower, more expensive, and more complicated. We know that as therapists. We treat patients who come in with complications, who thought that lumbar fusion was going to fix them, and they're actually worse before they went in and had the surgery, right? We've seen the outcomes. We know firsthand. We also have the data to support it. Of when that patient comes in and tells you, hey, I think I'm just going to try a labral reconstruction on my shoulder. I hurt my shoulder a few weeks ago in the gym, and it's just not getting better. And my doctor thinks I should have my labrum reconstructed. You should be very honest and upfront with those patients. You should be very blunt. You're going to do PT just the same after. It's going to cost you to have the surgery. And oh, by the way, do you know about the aftercare for your surgery? Because that's often something patients aren't told, of what it looks like to need to take care of themselves after surgery. Of, hey, do you know after a labral reconstruction, you're going to be in this abduction pillow where you can't use your arm for maybe 6 to 12 weeks? Are you right-handed? I am right-handed. Okay. You're having surgery on your right shoulder? I am having surgery on my right shoulder. How's the mobility in your left arm? Because if you can't reach your butt, you're not going to be able to wipe your butt after you have surgery. Who's going to come wipe your butt for you? Who's going to come do stuff around the house while you're trying to learn and now become left arm dominant? And these are important details that are often conveniently left out in that conversation with the surgeon. They make it sound so cut and dry and quick and easy, and we know it's not, right? We work with these patients after surgery. We know it's not. When we choose surgery ourselves, we also skip the benefit of learning about that injury, of how to modify things for that injury, of different exercises and different treatments for symptom relief that might be beneficial for that that injury area as well, right? Jeff did a really great episode. It's a couple years old now, from November 2021, but it's episode 1092. Jeff Moore, CEO. It was a Leadership Thursday episode. And I think it's a very profound episode that everybody needs to listen to. It's called Take One for the Team. It's about how we become better healthcare providers when we overcome our own injuries with physical therapy. We learn, one, the confidence that, hey, I overcame shoulder pain. I overcame flexion intolerant low back pain. I overcame anterior knee pain, whatever it is with physical therapy. I got back to doing everything. I got back to doing it symptom-free. I knew how to modify around it. I have that much more ability now to help a patient who presents the same way to my clinic now. So not that we're intentionally trying to go out and collect injuries, but when we do, we should see it as an opportunity to get better as a clinician while also practicing what we preach. Because my third point here is really what we're saying when we hurt our shoulder and we go get a debridement or a scope or an injection, is we're saying, do as I say, not as I do. Or another interpretation could be rules for thee, but not for me. Imagine you go to the dentist, you lay down on the chair, he says, hey, how you doing? You've been flossing? And you go, yeah, of course. And you literally lied through your teeth to the dentist. And then he opens up his mouth to smile, and you see a bunch of yellow, cracked teeth. What would you think about that dentist? Wait a second, why am I getting care? Why am I getting dental care from a person who clearly does not value preventative dental care, or really the care for his teeth and mouth at all? This person seems to be kind of a hypocrite of why am I letting this person make me feel so guilty about not flossing my teeth when clearly they do not as well? And then what if they go on to say, well, flossing and brushing, I guess you could do that. That takes time, though, so I just let my teeth get really bad, and when they hurt enough, I just get them pulled out and replaced with fake teeth. It's a lot faster. You think, oh my God, I'm never coming back to this dentist again. But that's literally what we're doing when we choose an elective surgery for non-traumatic insidious onset musculoskeletal condition. We're saying, I don't want to spend the time going to PT a couple times a week. I don't want to pay for it. I'm just going to go get surgery and then maybe deal with the bill later on. And we're not advocating for ourselves, and we're not advocating for our patients in that regard. I think often of the fear of flying I used to have prior to working for ICE and initially working for ICE, where I would drive to every course that we had. I would drive 12, 16, 20 hours to avoid flying. I was so scared of flying. And what got me over it was recognizing that flying is relatively safe in the data, and also kind of recognizing what helps me calm my fear on a flight is how calm and trusting the flight crew are on every plane. Of when the plane shakes and there's some turbulence, I don't look at other people. They're probably going to be panicked like me. I look at the flight crew. If they're still serving old fashions, I know, okay, everything's okay. I need to worry when the flight crew worries. Now, that would be a very different scenario if I sat down next to a pilot who said, I'm getting ready to go on a long cross-country road trip. And I would say, well, why don't you fly? Can't you fly for free? And they said, oh, no way. Planes are so dangerous. They're death traps. That would not instill a lot of confidence in me to fly. And we do that same thing when we rack up a bunch of surgeries and our patients ask us questions about how they can overcome their injury without surgery. And we really have no experience to draw on because we've always chose surgery first. So why are we so unique? Why is healthcare, why is musculoskeletal rehabilitation so unique in that we don't have to practice what we preach? And I would argue it's not. Like, this is the problem we have reaching patients. This is why so many people don't choose physical therapy first, is because physical therapists don't choose physical therapy first. We're always the first ones to help ourselves to a scope or debridement or injection when something pops up. And we're never the ones actually in the physical therapy clinic getting physical therapy ourselves. So why do we expect our patients to maybe choose a little bit of a longer road to a better outcome instead of trying to see if the quick fix will work for them when we don't do it ourselves? And then the counter argument here is always, athletes. Athletes always get surgery. When they blow out an ACL or something, they go get surgery right away and start their rehab right away. Well, the people that come into our physical therapy clinics are not usually professional athletes. Professional athletes are professional athletes. They are paid to train all day, perform, compete, and recover. Frank, who comes in, is not a professional athlete. He slept 4 hours last night. He ate a donut for breakfast with a coffee with 3 sugars and 3 creamers. He sat for 12 hours at work. He's only walked 800 steps a day. He's going to go home and have 4 Bud Lights and then get 4 more hours of sleep. His body is not in the best state for recovery, for fast recovery from surgery. He's not a good surgical candidate versus the professional athlete who's going to sleep 12 hours a night, who is going to take great care of themselves, both with movement and nutrition, is a much better surgical candidate. Also, they have all day to recover from that injury, to do their rehab, to sleep, to recover. Again, they're a professional athlete. We can't compare our general population patients and clients to professional athletes when they have a terrible environment for healing versus a professional athlete whose job is literally to do physical things and recover from them. When we choose surgery first, we don't smoke our own dope. We don't practice what we preach. And I think that's what bothers me the most about it. When I was in the Army, I had a company commander. His name is Captain Joseph Cannon. I really don't like that man, so I don't care that I said his full name on here. This guy had a general for his dad, and it was very clear that he was on the same career path to also want to be a general. And he had a bad habit of enforcing rules that he himself did not believe in or follow. He had a rule in place that if we were going to go to the shower or the latrine on base overseas, we had to be in full military uniform. We were not allowed to have open-toed shoes on or go in just our shorts. We had to get fully dressed, go, shower, use the bathroom, whatever, and come back. And yet every morning, here's Captain Cannon in just a towel, no shirt, and Crocs going to take a shower, right? That is a rules for thee, but not for me scenario. When you choose surgery first, you are Captain Cannon, right? I think of that every time somebody tells me that they're thinking about getting surgery versus trying physical therapy and they're a physical therapist. I think, wow, what a real Captain Cannon move to do. So until you accept the fact that people follow people, that leadership occurs at the front line, you'll always struggle with reaching the majority of your patients from whatever target population you want to treat and having them complete their full plan of care and maybe even come in for maintenance or refer their family or friends to you and grow your practice significantly because you don't lead from the front and people know that. They see it on social media. They see when they call to make an appointment for you and you're out yet again for 6 weeks to recover from a surgery. They think, I'll go see an allied healthcare provider. Maybe I will try that injection that my doctor recommended, or I'll try that exploratory debridement or arthroscopic procedure and just see, right? I can't get into therapy anyways. My therapist is on leave for their own surgery. So start leading from the front. And man, if you're going to say that you tried physical therapy, you better have actually done physical therapy. So often we hear, I tried some physical therapy and it didn't work, so I got surgery, right? Well, when we ask physical therapists, what did you do? They usually say something like, well, my coworker needled my glute twice. Okay, is that physical therapy, right? If a patient said that, would you say, oh, you had a successful run at physical therapy, then you got the full package, you got your butt needled twice? No, we'd say, that doesn't seem like physical therapy. Like, did you try any exercises or any sort of progressive loading or lifestyle management or anything else? You got your butt needled twice. That's not PT. That's just having some needling done. If you're going to say that you tried physical therapy and it didn't work, you need to give it the full college try, right? Book an appointment with the PTs that work at your clinic or a different clinic, whatever. I think it makes sense to support the people you work with in your own clinic, but you don't have to. Try it like a patient would, of what you would expect a patient to do when they tell you that they have actually tried physical therapy. Did you go twice a week for an hour-long appointment? Did you, yes, do manual therapy, but did you also do progressive loading? Did you do activity modification? Did you do everything that you would deliver to a patient? Or did you just try some passive stuff a few times? It made no difference, and now you're on the schedule for surgery. Because often that's how I see that it went. And that's very infuriating to call that physical therapy. We would be very upset to hear a patient tell us that was their physical therapy experience. So why do we do it for ourselves, right? Physical therapy is the consistent and progressive approach to reducing symptoms, improving function and performance of an individual in a manner that, yes, utilizes manual therapy, yes, uses psychologically informed care, but also involves really diligent loading. Like we're strengthening tissue, we're increasing capacity, and we're moving beyond initial injury baseline to improve quality and quantity of life. And we don't get that when we just get our butt needled a few times, right? So actually try it, actually do it. Make those appointments, schedule it out, hold yourself accountable, try it for a couple weeks, try it for 3 months, and see if that injury doesn't magically get better instead of having a scope, instead of having a debridement, instead of getting an injection. And my final point here is that if you are going to choose surgery first, if you are not interested in trying physical therapy first in a diligent manner, don't ask me about it. I don't care. I think that you're a quitter, and I don't care who knows that I think that, right? Of the problem with physical therapy, not supporting physical therapy, will always be a problem in our profession of when we choose to have our butt needled twice and then get surgery. That is going to be the standard of care that our patients see or our potential patients see, and that's always going to limit the public perception of physical therapy in a very negative way. So when we choose surgery first instead of physical therapy, we are part of the problem of why more people don't come see us, why people don't value what we do, why they don't want to pay for that value, and why they don't want to hang around longer afterwards or send their friends and family to us. And then when you start becoming the person who has encountered injury, overcome it with physical therapy, you'll tend to find that the phone rings a little bit more, that people complete their plan of care a little bit more, and that they tell your friends, they tell their family, they have their kid come see you, their kid's friend on the softball team that hurt their shoulder at practice shows up on your schedule because they know you're the person that's going to get that better, and you're the person that is kind of against surgery in your community. And that's okay to be that person of, yes, surgery has its time and a place. If you get plastered by a bus, you're probably going to need some surgery, right? If you have something going on congenitally, you're probably going to need some surgery. Surgeries are impactful for the reasons they were created for, but just having them to have them and hope they work is not a strategy. Being diligent with physical therapy, being accountable, actually, quote unquote, trying it is a strategy. So start trying physical therapy and try surgery a little bit less. I hope you have a great Easter weekend, a happy Good Friday. I hope we see you at a live course soon. Have a good day. Have a good Friday. Have a good weekend. Bye, everybody.